Hi, everyone. Thank you for attending CIL's Mass Spec Isotope Day 2024 webinar. I am Dr. Andrew Percy, a senior applications scientist at Cambridge Isotope Laboratories, and I will be moderating today's webinar. This marks the first of a three-part series of Isotope Days featuring science facilitated by stable isotopes. The Isotope Day webinars that follow in the weeks ahead are devoted to NMR and environmental applications. An overview of those will be followed in the close of the webinar. The Isotope Day webinar features some exciting presentations from 4 scientists across academia and industry who will be covering a variety of topics in the mass spec field. Their content is diverse, providing you with insights into some cutting-edge applications that utilize stable isotope labeled standards and/or mixes. Included in the goals of today are that you learn something new, strengthen your understanding of CIL's labeled products, and most importantly, stay engaged. The program for today's Mass Spec Isotope Day webinar is outlined here. The speaker order is bookmarked by Doctors Melanie Cree and Will Thompson. Each speaker has an allotted 20-minute time slot with approximately 15 minutes dedicated to speaking time and approximately 5 minutes for Q&A. The presentations will be recorded, and as a reminder, please type your questions into the Q&A box along the way, and I will deliver these to each speaker during their respective Q&A period, as time permits. Before moving forward with the scientific talks, I'd like to take a brief pause and ask that you please complete this short 3-question poll. The questions are general and in multiple choice format. Your responses will help us gain insight into your research background and application interests. So if you wouldn't mind, please go ahead and complete them. Just one more minute. Looks like things are slowing down. 30 more seconds. Okay, we can close the poll. And we'll now dive into the scientific talks, beginning with Dr. Melanie Cree. Melanie is a physician assistant and pediatric endocrinologist at the University of Colorado and Children's Hospital of Colorado. Melanie's research focuses on the role of hepatic fat as a marker or mediator of progressive dysglycemia and cardiometabolic health in pediatrics with obesity. She uses non-invasive approaches with stable isotope tracers to probe physiology to gain an improved understanding of metabolic disease in pediatrics and to ultimately develop new therapeutic clinical targets. She has published an abundance of articles in impactful journals over the years, and today she will present a snapshot of some of her latest work in this growing research area. Melanie, the floor is yours.
Thank you. I'm very excited to get to show my work to a new audience who may not know what I'm talking about, and hopefully at the end you'll be able to tell us a little bit more about it. So I'm going to talk about our stable isotope use in understanding metabolic disease in children with children. I don't have any conflicts to declare. I am a site PI for clinical trials with AminoCo and Eli Lilly. So today, the backdrop of the disease that I'm working in is called Polycystic Ovary Syndrome. And this is diagnosed by menstrual cycle irregularities and then elevated testosterone or signs of elevated testosterone, which in women is growing a beard, severe acne, can be very distressing. We also use ultrasound criteria in adults. And so why do we care so much about polycystic ovary syndrome? And it's because what it's related to. So PCOS is the #1 female infertility within the United States. And once women do get pregnant, they have much higher rates of pregnancy complications. Women with PCOS and girls with PCOS are much higher risk for developing obesity, and in particular type 2 diabetes. We found that our teenagers in Denver are 11-fold higher, more likely to get type 2 diabetes compared to youth in the NHANES survey. Approximately 60% of our youth have metabolic associated steatotic liver disease, and there's also increased risk for hypertension, hyperlipidemia, and sleep apnea. And in addition to these, PCOS has been shown to be significantly associated with anxiety, depression, sexual dysfunction, as well as the dermatologic features, the hirsutism, which is excess hair, acne, and balding. And PCOS is thought to affect 6 to 15% of women in the United States. And when you look at women who are struggling with weight, it goes up to 20%. So 1 in 5 women in the United States who are struggling with obesity have this syndrome with all of these significant outcomes. So I've been working in this field for more than a decade now to try to understand the underlying metabolic disease in hopes that we can come up with a new treatment for PCOS beyond what's available. So my first question was, is there metabolic syndrome in youth with PCOS? And is it the same as what we see in adults? So really, this is focusing on insulin sensitivity across the body. So we did a 3-stage hyperinsulinemic-euglycemic clamp with stable isotope tracers. And what we're measuring there is adipose insulin sensitivity, hepatic insulin sensitivity, and muscle insulin sensitivity. We then did an MRI of the liver and abdomen to look at liver fat and visceral fat. We did 31-phosphorus MR spectroscopy to look at muscle mitochondrial function to compare to our muscle insulin sensitivity, a DEXA for percent body fat, indirect calorimetry for metabolic rate. And when you combine that with a glucose tracer, you can get non-oxidative glucose disposal. And then we did a carotid ultrasound to look and see if these girls had plaque. And this is the study design with the tracer. So a hyperinsulinemic-euglycemic clamp is we give an individual a high amount of insulin, and then we see how much dextrose we have to give them to maintain their blood sugar. The more dextrose we give, the more insulin sensitive you are. So the first part is the basal, and here we're not giving any insulin. We're just seeing how the body works. Then we turn and the tracers, and in this case I used 662 glucose and D5 glycerol. The tracers are turned on right at the beginning. You let them come to steady state, and then we do sampling at the end of this steady state to see what the basal rates are for glucose release and glycerol release. Then we do a low dose of insulin. This should suppress fatty acids and lipolysis, but nothing else. A medium dose of insulin, this should suppress glucose rate of appearance, so it's ideal for your hepatic insulin sensitivity. And then we put the dose much higher so that you can look at maximal insulin stimulated glucose uptake. So what we found was that these girls had adipose insulin sensitivity. We could not turn off their lipolysis. They had decreased liver insulin sensitivity. So even with a large amount of insulin, their glucose rate of appearance persisted. And they had muscle insulin sensitivity so that their glucose infusion rate was lower. We also found that they had decreased muscle mitochondrial function, increased liver fat, plaque in their arteries, but no difference in terms of overall body composition in terms of percent fat, and no change in their resting metabolic rate. And what was really interesting was that we found that the amount of liver fat related to our metabolomics data in terms of relating to markers that are thought to represent de novo lipogenesis, in particular 16-1 and 7 palmitate. So that's your 16 carbon palmitate with 1 double bond at the 7 position. So based on this, we came up with this model that PCOS, when combined with obesity, leads to increased intrahepatic triglyceride, and that it is this excess intrahepatic triglyceride that's allowing for the development to type 2 diabetes, cardiovascular disease, and MASH. I need to update that. And so this is the premise that my lab has been working on for the last 10 years now. So one of the things when you think about liver fat is that it's made in the postprandial time period, not fasting. And the majority of tracer studies are designed to be done fasting because of the steady state. So what we had to do is we had to design a protocol for drinks with tracers. And so what we wanted to do is we wanted to look at, we needed a glucose tracer so we could distinguish the absorption of glucose from the gut from the release of glucose from the liver. So now we need 2 glucose tracers. And we needed to mathematically model the results because we are invalid in terms of having a steady state. And then we used acetate to measure de novo lipogenesis. And so this is what the protocol looks like. Now here, the acetate, we had to admit these patients to the hospital, and we started running the acetate at 7 o'clock at night. And we ran the acetate all the way until 2 o'clock the next morning. Now this part, the D5-glycerol and the 662 glucose, this timing is identical with a 2-hour basal period, but now we are giving a drink at 8 a.m. and this had 1C13 glucose in it. And then we had frequent sampling, and we initially started out with 6 hours. So what we found was that de novo lipogenesis was increased in those who had higher liver fat, so that relationship is intact, but there wasn't an increase in PCOS per se. So here below, the gray dots here, this is the PCO only data. The gray dots here are those who have lower liver fat, so their liver fat is under 5%. And then those who had higher liver fat in these black triangles had higher rates of de novo lipogenesis. And then we still have not figured out the math for this. So what happens is when you give your 6,6-D2 tracer, while it's D2, it can get broken down and you'll have an increase in your M+1. We're then giving a carbon M+1 drink. And so what's happening is at the end of, or about halfway through the glucose drink, when the M+1 glucose should be coming down, it's staying high. And so our mistake here was using an M+1 glucose. So were I to do this again, I would use an M+6 glucose so that it's very distinct from any M+1 that is being recycled or is coming from our M+2 glucose. So results still to come. And I've got a great mathematical modeler that I'm working with. So now I'm going to switch tact a little bit to talk about what is an isotopomer versus an isotope. So for an isotope, we would just say mass +1, for example, in glucose. An isotopomer, we're actually paying attention to where in the molecule the label is. And so, for example, in glucose, you've got 6 carbons. Your carbon can be in 1 and 2, 2 and 3, or 1, 2, and 3. But if you were looking at isotopes, this would just be mass +2 for the first 2. Whereas with an isotopomer, you can distinguish between the 2 of these. So we started working with Dr. Craig Malloy at UT Southwestern to look at these isotopomers. And the way that you do this is you change the way for analysis. So typically with tracers, we do LC-MS to get your overall mass. With the isotopomers, they're actually doing this with magnetic resonance on a 13 Tesla magnet. And so how you can use this is you can use this to understand intrahepatic metabolic pathways. So you give a uniformly labeled carbon-13 glycerol. So you've got your labels at 1, 2, and 3, and it's primarily taken up by the liver, again, with a drink. And if it goes through fatty acid synthesis, the label will come out in the glycerol backbone of newly synthesized triglycerides. The label can come out in glucose, and when it's gone through the TCA cycle, the label will be in 4 through 6. If it goes through the pentose phosphate pathway or directly through gluconeogenesis to then be released from the liver, then what you're going to see is your label is in 1 through 3. And so with this, you can see that this is really kind of opposite to what we expected, is that the individuals who had fatty liver were putting less glucose through the TCA cycle. We were expecting that they were going to have increased hepatic cycling to lead to increased de novo lipogenesis. And rather, it looks like there's an entire intracellular interhepatic shift. And this is all published if you want to read more. So we had to figure out the timing of this because insulin sensitivity is different in girls with PCOS. So the first thing we did was adapt the adult protocol to one appropriate for kids. And this is data from this. And then once we developed the protocol, we said, well, we want to look at the blood, but we also want to look and see what's happening in the liver. We theoretically think we're presenting what's happening in the liver, but let's check for real. So we did this study in patients who were undergoing bariatric surgery. They had an average age of 17, very large, obviously, with an average weight of 135 kilos and a BMI of 48. And the majority of them had some degree of liver disease. So what we did is they were fasted overnight, and we came in and met them in pre-op and gave them this UC13 glycerol drink. It's a very small amount and it's clear, so anesthesia let us. And then when they went to the operating room, we took a liver biopsy and took blood at the same time. And we actually found a new mammalian pathway in the liver, which is pretty exciting. So, and we found that the blood matched the liver. So indeed, using the blood markers for this, this is valid. And so what we found was that, you know, the glycerol will come in, you can get your gluconeogenesis as we expect to 1, 2, and 3. But that as we came down the metabolic pathway, and came out through the TCA cycle, either at this location or here, the glutamate can come out at 4 and 5 or 2 and 3, and that this can be used for making glutathione. What we didn't know is that glycine can also be used to make glutathione. And so glutathione is one of the primary reactive oxygen species that are primary components that manages the reactive oxygen species and is thought to decrease the conversion of simple steatosis in the liver into an inflammatory hepatitis leading towards steatosis hepatitis, which is more serious. And so our thought is that when you've got excess lipolysis, the liver takes in the free fatty acid. It's having to deal with that. You've got extra glucose. We're making extra liver fat. So now you've got all this extra liver fat. But if you have excess glycerol, the excess glycerol can be put into more glutathione to actually mitigate the reactive oxygen species made by the excess liver fat that's being made. And so we want to do some animal studies now to confirm this. So then the last thing that I'll show you is we wanted to see, well, what happens if you use some of our classic medications for weight loss in the setting of these drugs? And so we did a clinical trial where we wanted to look at the effect of oral semaglutide on weight, reproductive, and metabolic outcomes in girls with PCOS and obesity. And this started before COVID and before any of the injectable glucagon-like peptide 1RA drugs were on the market. So ones that you may be familiar with, Ozempic and Wegovy are the brand names for semaglutide, which is in the news a lot. So this is the oral semaglutide. So phase 1 was no randomization for safety measures by the FDA. And once they deemed that the medication was okay to proceed, then phase 2 was 1-to-1 randomized with an intensive diet. And the participants met with a dietitian once a week. And I had a metabolic study at the beginning and the end of each of these. And so this is what the metabolic study looked like. So here we are now using deuterated water instead of acetate to measure our rates of de novo lipogenesis. And then we're using the UC13 glycerol for that isotopomer analysis. And we're measuring these in the fasting state. You've got your basal period there. Then we give the glucose drink and we're measuring these in the postprandial state. And we're doing this before and after the semaglutide. And so I just got the de novo lipogenesis results from Dr. Elizabeth Parks yesterday. So I don't have the results of those. But what we found, if we go back to here, what we've found is that the girls who received semaglutide had a shift from excess TCA cycling, which is thought to be unhealthy, to direct gluconeogenesis. And so what it looks like is that with the semaglutide, the intrahepatic metabolism has changed to a way that is thought to be more healthy and have reduced ROS production. We are putting together the presentation of this. My graduate student will be presenting this at the Obesity Society, which is why I'm not showing you the graph of that data, but you can see it there. So it looks like in the individuals with the semaglutide, we're seeing this real difference. Now, what we need to do is look at that as relates to changes in the degree of liver fat and changes in how much weight they've lost. And so those are the secondary analyses that we're doing right now. So you can see that at TOS if you would like. And I will stop there.
Thank you very much, Melanie, for that excellent talk. Very interesting work. We have a couple questions from the audience. So in the interest of time, I'll deliver one of these and maybe you can address the other one afterwards.
Okay.
The question is from Jinming Singh, and it is, what is the best practice for determining the amount of tracer used to assess severity of metabolic disorder? Would you do a fixed dose or a weight-based dose? And how do you determine the dose level considering patients may have trouble metabolizing the tracer efficiently?
So this is where I've gotten really lucky that a lot of this work has been done previously. All my dosing is done based on weight, and we use kilos. Where I've gotten lucky is that in that initial study, I showed you that the percent body fat and the percent muscle mass are similar in the patient populations that I'm looking at. But what you can do, and this is what we did with at the beginning of the drink with the carbon 13, is you do a couple participants, you stop your protocol and you pick your doses based on what's in the literature and what seems appropriate for your patient population. So you do a couple patients, you stop your protocol, and you analyze and run all of that data. And then you see, does it look like your enrichment is too high so that you may actually be affecting the underlying metabolism? And you can also do this with the non-tracer. So when you give that glucose in the basal period, for example, and glucose is easy because you can do that bedside. So here, if you're giving too much glucose, your glucose concentration is going to increase. So say you're starting with a fasting glucose of 90, and at the end of the 2-hour basal period, your glucose is 95 and it's consistent. You're giving too much glucose because you are actually affecting the physiologic baseline. But this is one of the #1 tenets of doing stable isotope tracers that we teach at the stable isotope course with Cambridge, that whenever you're doing a tracer trial, you need to do 2, stop, look at your data before you take any more time moving forward.
Thank you very much for that thorough response. There are some other meaty questions from the audience in the Q&A box, so I'll leave that to you. And
Okay.
we'll move on to the next speaker. Thank you once again for your talk.